Savitri, can we start?
Sharik ji, please give us a count and then we can go live.
The webinar is live now.
So, good evening, everybody, and welcome once again to the WOS Teachers Connect webinar. And this Teachers Connect group was formed last year, somewhere around October or November. And the whole aim of this was that we connect all the teachers, we try to understand what the challenges are which they are facing and how to overcome those challenges. And and we did this in the last few webinars. We also discussed things like how we could improve the teaching methods which are already existing. And there were a lot of interesting discussions and a lot of things came out of it. And Dr. Shweta Walia and team are also writing a consensus statement on that. Which we hope would get published with everybody's names also there, so that this would help all others also. We didn't want it to stay with a certain group of teachers. We wanted it to be spread across to everybody so that everybody can benefit from this consensus statement which all the teacher which the group of teachers came out with. Now today we have a very interesting topic again, and that is to do with learning and teaching. We often talk about the student teacher relationship no longer being what it used to be a few years back. So we need to understand, where is that missing link? Is it the teachers to blame? Is it the students to blame? Or is it nobody to blame? We believe it is nobody to blame. It is just that we need more discussion on it to find out where that missing link is, and what are the reasons. Maybe it's a change in lifestyles. Maybe it's more of mental pressures. Maybe it may be many things which will come out today in this webinar, and then we can find solutions so that we have better and improved such relationships between teachers and students, and our teaching actually translates into learning. So again, as we were discussing a little earlier, this is not there in any of the textbooks, but you are the best minds to tell us what should be done about it. So over to Dr. Shweta Walia, who's the brain behind all this. Dr. Shweta, please start with your proceeding.
Thank you, Dr. Moita, for providing a platform to all the teachers. And with this, we educators we learn where are we actually reaching our learners. And today's session will address this very gap between the teaching and the learning, and will explore how we can become more effective, adaptive, and be impactful educators. We are privileged to have with us distinguished guests, experienced speakers, and a dynamic panel who will bring a wealth of knowledge and real-world teaching experience. We have with us a special guest, Dr. Divya Manohar. We welcome you, Dr. Divya Manohar. It's an honor to introduce you. And she is widely known for her contributions to ophthalmic education and her commitment to structured and meaningful teaching practices. We welcome you, Dr. Divya. We also have with us Dr. Radhika Natarajan, and she's a stalwart in ophthalmology and a respected mentor to many, and her vast experience and deep insights will bring immense value to this session. We also have with us an experienced panel of teachers. We have with us Dr. Modini Pandarpurkar. We have Dr. Meenu Ramakrishnan, Dr. Rekha Khandelwal, Dr. Archana Vare, Dr. Manvi Sindal, Dr. Sai Kirmai, Dr. Hema Nandini. And I think all of us, all the panelists will definitely contribute today, and we'll all can have a look how we are not able to reach our residents and the students, and why the connect is missing. So for the today's first talk is by Dr. Natasha Radhakrishna, and she'll be speaking on handling difficult learning behaviors in residency. Dr. Natasha, we look forward to your insights. Over to you, and please share your presentation.
Thank you, Mohita ma'am, Dr. Shweta, and the rest of the WOS team for this opportunity. I'm happy to be here to share my insights about how to tackle difficult learning behaviors. Are you able to see my screen?
Yes, it is visible. You can make it full screen. Yes, yes, please.
Okay. So I have close to 17 years of teaching experience, both UG, PG, and fellowship teaching. And this is a small outline that I have made based on my the experience. And I hope to share with you some of the anecdotes during our discussion, what we have encountered and how we have tackled them. Though the lecture itself is a bit of a didactic lecture, but I'm sure at the end of it, we will be having a very fruitful discussion about our experience in tackling these problems. I request everybody to please mute. So why does this matter that we should know how to tackle these difficult learning behaviors? Matters because residency now is a high pressure learning environment, and these behavioral more important than that. Can somebody please mute Mr. Bharat Muthutangam? Please mute.
Requesting all, mute yourself.
I think the host can mute if the host is active. They can mute everyone except me.
Hariji, please mute. I think it's done. You can please continue.
Yeah, in residency, the most important thing is that these behavioral issues do not impact just themselves or the teachers. It impacts patient safety, it impacts functioning of the team, it impacts learning outcome for the residents. And with increasing recognition of resident well-being and professionalism during the course, it is important for us to know how to tackle this. And this talk is about managing and not avoiding. And it is an educational responsibility from us teachers to tackle these difficult behaviors. It is not just a matter of enforcing discipline. So, what are difficult behaviors? Difficult behaviors are recurrent behaviors that disrupt team dynamics, impair patient care, and interfere with learning. So, we should make the distinction between difficult behavior and behavioral issues that the child may have and learning difficulties that the resident may have, though I must admit there will sometimes be overlap between these two. So the common behavioral profiles in residency are a disengaged or an apathetic resident. You know, the resident who is not bothered about the patient care, who is not bothered about any scolding you give, who is not bothered about the outcome of what his residency is. That kind of behavior we often see. The second kind of behavior is a defensive behavior and resistant to feedback. The person will do whatever he is doing, and if you try to correct that person will say, will not accept that kind of correction. And that is called resistant to feedback. There is another unsafe or overconfident resident, the first year resident who does something that even a final year resident would or a consultant would be like worried to do. That person has no worry at all, and he or she will cause unsafeness to our patients because of this kind of behavior. The anxious or the overly dependent for everything, some of the first year residents will always want an opinion from the second year or the third year. They will not do anything on their own, even in spite of multiple months of residency. That is the anxious and the overly dependent resident. And sometimes the resident who is always fighting with the others, which is either with the staff or with the support staff or with their own resident colleagues, peers, and seniors. So, interpersonally difficult behavioral problems. You can have difficult learning behaviors in which there is poor clinical reasoning, there is inconsistent performance, there is a lack of insight that they are not actually learning properly, there is poor application to whatever you tell. They seem to be understanding, but they don't apply it in what they are doing, and difficulty to integrate the feedback that you are giving and to change the behavior. Now, the important thing to first look at is the underlying causes. So, usually, the underlying cause is a framework of personal factors like burnout, stress, and other issues in mental health, educational factors. Some of them come without a proper UG training or a proper, exposure to the things that they should have been exposed factors like increased workload. Sometimes they're not used to the kind of workload that they are given in the first year or in the second year. And then sometimes there is a toxic culture. Either the seniors or the consultants are putting a lot of undue pressure and undue personal anger into the then of course that now, how do we faculty identify that this person is a difficult behavior resident? These are the red flags that we should look out for. One is the same errors being repeated in spite of telling them again and again. Once you have repeated similar errors, just mark it and keep that this person will require more help. The second is feedback not translating into change. You have told them time and again that this problem is there, but they are not changing whatever problem that they are doing. Conflict with multiple team members, either with peers or with the seniors or with the support staff. Avoidance behavior. You tell them something to do something, they don't do it, they put it on someone else. They try to see that you don't understand that it is being put on someone else. That kind of avoidance behavior. And of course, endangering a patient safety concerns in which they are not actually looking at the things that they should look at for the patient safety. The common pitfalls that happens in even after identifying the red flags, faculty, the problems that happen is one is we ignore early signs. We do not recognize the early signs of difficult behavior. Second is that instead of diagnosing the actual thing, we just label the person as, oh, this person possible. We cannot really do anything. I don't want anything to do with this person. So that kind of labeling happens. Public criticism. We take them to task in front of everyone else and tell them repeatedly in front of everyone else, ridicule them, or at least make them, we are not actually intending to ridicule them, but they feel ridiculed in front of their peers. The fourth is inconsistent feedback. One time you correct, one time you ignore, third time you get angry, fourth time you don't do anything. That kind of inconsistent feedback. And finally, delayed intervention, that you have not actually tried to correct the behavior properly and in time. So what are all the things we can do if we identify a person with a difficult learning behavior in our cohort of students? The first thing we should do is to identify, of course, early identification. This can be by direct observation. So always remember that you may get a lot of gossip from other peers and other staff. So we should learn to separate the wheat from the chaff by actually observing and spending some time to find out if the feedback that you have got from everybody else is correct or not. So direct observation is always the best. Multi-source feedback will give you some idea of their difficult behavior being there. Over time, you will learn to recognize the pattern of difficult behavior. And finally, documentation. You should be able to document that there is a person who's having trouble. Now, early identification will allow for constructive intervention and it will minimize the impact patient care and team dynamics. Second is a structured assessment. So you have to try to find out, is it a knowledge gap? Like we said, is it because the person has not been exposed to such kind of an environment or learning prior? Is it a skill deficit? Is it something that can be overcome by repeatedly making the person do that thing? Is it like a difficulty to do something because they are not used to doing that, or is it an attitude and behavior issue? Now you can use, when doing a case discussion, you can use that case discussion to assess whether it's a knowledge gap or a skill deficit. You can use direct questioning and find out. You can also use workplace based assessments. So you have to move from subjective impression or from someone else, someone telling you there is a problem, to evidence based, that you have seen for yourself what the problem is with the resident. The third thing is to give effective feedback. So you have to give timely and specific feedback and see that you focus on that particular behavior and not on the person. So you don't say you are a horrible person or you have a bad personality, or you do not have a good what is it called, interpersonal relationship. So you do not focus on the person, you focus on what they have done particularly bad at one point of time. So you tell them that this particular behavior is unacceptable, and that is the way you have to progress. And always see that your feedback is given in a private setting and not yelled at in front of the rest of the peers, and not yelled at during class and things like that. Now you can use a framework. For example, it's called a situation behavior impact. So during the rounds, you interrupted somebody speaking. So you say that during this, in this particular situation, this behavior of yours impacted team care or impacted patient care, and this thing that you would like, it would be better that you change it for future, so that you can be a better resident and a better doctor in the future. And this approach will minimize defensiveness and will promote self-reflection. For handling the defensive resident, you have to expect an emotional response, avoid confrontation, and try to make them talk about the problem. How do you think that went? And align on shared goals. Some of them do very well if you share a goal that, I would like to see this from you in 2 months from now, or I would like this project to be done by you because I think you can handle that. And that kind of trust from you will always bring out the best in them. So there are people who respond to that also. Now, remediation strategies: individualize a learning plan if you think it is a knowledge gap. Give the person clear, measurable goals so that they can work towards it. See that you give increased supervision to the people who are difficult learners, and you can schedule review meetings so that you know what has happened to your feedback. And it does all this should be individualized, should be supportive, and should be goal oriented. Now, supporting difficult learners, you can break tasks into smaller components, repeat and reinforce, encourage reflection, assign mentors. If you cannot do it by yourself, you can assign a mentor who can take care of it for them. And this improvement should always be acknowledged, should be supported, and lack of progress should prompt escalation. When behavior is the issue, set clear expectations, define acceptable and unacceptable behavior. When you find something unacceptable, take them privately and tell them that this kind of behavior is unacceptable. Consistency across faculty. If you have faculty who support them and speak behind your back, then you will not be able to go forward with it. So get your faculty, rest of the faculty also involved in the care of that particular difficult learner. And if needed, you have to give formal warnings in the form of memos or emails. Now, when do you escalate? So it's also important while we support these students, we should also remember in the present situation that anything can go wrong at any time. And if it goes wrong, like suppose there is a suicidal risk or something that is beyond your control, it is possible that the whole thing will boomerang on the teacher who was actually supporting the student all the time. So for that, to keep yourself safe and to keep the students safe, it is important to know when it cannot be handled by you. And for that, you should remember persistent non-improvement. You have tried and you have failed. Professional misconduct. If it is something higher than just small lapses of memory or something that is not being done, if it is something like a deviant behavior, if the patient safety is repeatedly put at risk, and if you seriously think the person has mental health concerns. In the just as a teacher, you should not be taking on the responsibility yourself. You need to escalate it. How do you escalate? First escalation is, of course, to your peer faculty. Second escalation should go to the HOD. After the HOD, if it does not stop at that point, from the HOD, it should be escalated to the head of the institution, and most importantly, the parents and the caregivers. So, especially when the last thing is their mental health concern is there for a student, I always believe that it is important to get all these people involved because things can go wrong at any point. And as a teacher, you have very limited role in changing their behavior. The challenges for us as faculty is time constraints. We really don't have the time to give individualized feedback and individualized support to all these students, but it is something that we have to try to do. Emotional burden is high because you tend to be worried about them and then carry that burden home, and that adds to the already big burdens that we carry between work and home. Balancing support versus discipline, you can end up being too friendly to that person, and then finally they turn that on you and don't agree to or don't listen to you properly. And of course, fear of conflict when you don't want to actually face or take discipline into your hands. So finally, what can we do? We can create a supportive learning environment so that there is psychological safety, open channels for communication, normalize that teachers will give feedback, and of course, be a role model yourself in terms of professionalism at workplace. So the key takeaways that I want to share in this talk are difficult behavior is often a symptom and it is not the diagnosis. More time and effort will be needed to reach a diagnosis in what we spoke before, whether it is a learning knowledge gap, whether it is a skill gap, or whether it is an actual attitude problem, and whether it is something worse than that, like a mental health issue. Early recognition is critical. A structured and empathetic approach works best, and faculty consistency across faculty is absolutely essential. And we should always keep in mind that we are not just training clinicians, we are shaping professionals of the future. I thank you all for your patient hearing. I hope I was able to do justice to my topic, and we'll take up more for discussion later.
Thank you, Dr. Natasha. That was beautifully presented, and suddenly it opened eyes for everybody that it has to be a structured approach. And when we give a general statement that the students are not behaving properly or the students are not working properly, it cannot be a general statement. You have to identify into various, as per the groups that you said, whether it's an over defensive one or it is, and then accordingly take the remedial action. So it actually looked like very, very structured. So thank you for this. And uh, let's start with our special guest, Dr. Divya Manohar, who has a lot of experience herself on this topic. And we would like to hear your views first.
Good evening, ma'am, and thank you for this wonderful opportunity. A well-spoken talk. I think feedback is something that is very important that we have to give the students quite often, because a lot of times we just call them and tell them that, this could be done this way, but we don't reason out as to why this should not be done in such a way. And again, I think skill and knowledge is something that can be improved, but when the attitude is not there to learn, or when they don't want to accept what we want to teach them, then again that's a very challenging situation. And there's also this safety concern. They have this fear of being judged. What if I don't know the answer? What if I don't answer well? Will they reprimand me, or will they or will they ridicule me, or what will the others? We always have that fear. So I think that is something we have to tell them, that we have to be non-judgmental, make sure that no one in the class or in the surroundings, everyone is bound to make mistakes. So I think if we as teachers agree that I don't know the answer, or I can make a mistake as well, if we're ready to accept that, I'm sure students will learn much more. And I think it's always important to praise them in public and reprimand them in private. I think that's very, very important, tell them their feedbacks and everything. And teaching is what we do, and learning is what they do. So there's always a gap, and we should see how we can fulfill that gap. Yeah. Thank you. Thank you, madam.
Thank you. Now I would like to ask one of the panelists, any of the panelists. Dr. Archana is there? Dr. Archana Vare, I could see.
Yes, ma'am, I'm here. Yeah.
So the last part of the talk of Dr. Natasha, where you have to protect yourself also, and you have to remember that there is a time that you have to identify that this can become dangerous to your own self also. Can you comment on that part also? Because we have been seeing a few such incidences all around, and it is worrisome. So that part is also important.
Yes, ma'am. It's extremely important to understand their mental health issues, and we have to refer them. Timely referral is extremely important. and to the psychiatry department or the head of the department of the psychiatry, and you should speak to them, speak to the HOD yourself, and then if it is possible for you, you should accompany the student, and you should always inform the parents that you are, I mean, this student is having so and so problem. So with the parents, you should, I mean, because recently I had faced this problem wherein a student she was having some mental health issues. So we called the parents, and we should have a faculty meeting beforehand, and then we should discuss it across the faculty members, because everybody should be aware that the student is undergoing some problem. So that all the faculties they have, otherwise if the student is not following something, then the faculty may scold the student or whatever. So the faculty members, they should be taken into confidence, and you should always have the HOD or the senior faculty from psychiatry department, and you should take their opinion, and whatever advice they give you, we should follow that advice. So it's
You
very
also
important.
feel that some teachers say that students today want a shortcut, and they are in and that is because they are in extreme mental pressure, because there is so much of competition, etc., that they are anxious, rather they are anxious. So is do you think that is true, and what would be the solution for such a
Yes, ma'am, it is extremely, I mean, it is evident because we can feel the change in the behavior of the students. Now I've been in this profession since last 23 years, so I can feel the change in the behavior of the students. And means earlier the students had a lot of patience, but now the patience is gone. Maybe because of the screen that they see reels only for a few seconds, because they don't have the patience to see reels. So that's why they make very small reels. So from that also we can understand that they have lost their patience. And that's why because of this lack of patience, there is change in the behavior of the students. And that's why they need more of spiritual learning, but they're not interested in that. But then if we refer them, then we also become safe. And the psychiatrist also tells them what behavioral changes they should adopt to. And their parents are also made aware that your child is facing such and such issue. So they also try to, intervene and do the needful for the child.
Thank you.
Sometimes
So
a child will say that they do not want the parents to be involved, but I think as teachers we should take a call for on that, and we should inform the parents, because finally, like I said, when things go south, everyone will just blame the teachers. Especially the most supportive teacher will end up with at the wrong end of the stick. So it's very
Yes,
important to get
this
everybody in the
this
loop.
stigma or this taboo of being,
Yeah.
called saying that you have a psychiatric disease, or again, that also has to be handled in a very gentle
Delicate
way, I
manner.
feel. Yeah,
That's
it,
not
it, it
something that
is
we
quite a
can actually
sensitive
do.
topic. Yes,
Yeah.
yes. So that needs a lot of priming before you even put it across to the parents, because a lot of times it's only denial. They're in the denial mode. No one wants to accept the fact that the child is suffering. So I think that can also be
But
quite
we are
delicate.
seeing
So
the
we'll have to
incidences
handle.
happening every day and night. So that's why we have to be more vigilant, because we are seeing like small pressures, and they do whatever. I mean, they can take any step. So that's why we have to be like more careful. And it is very important to take into confidence the parents and the faculty members. It should be a team. So all the team members, they should be involved in this particular thing.
So, is Dr. Modini also there? Dr. Modini or Dr. Minu Ramakrishnan? Okay, I can see
Yes,
Dr.
ma'am.
Manvi's, Dr. Minu Ramakrishnan is there.
Yes, ma'am.
Uh, so just wanted to know from you, because Dr. Natasha also talked about burnout. So do you think this is an actual phenomena which is happening, and which may be one of the reasons, and what we could do to prevent that burnout in the students?
Yes, ma'am, definitely. there is an element of burnout which happens, but I
You got muted. You are muted right now.
yeah, sorry, can you hear me?
Yes, now we can.
Yeah, I know that when during our
Introduce
residency,
yourself. Sorry, we did not introduce, so you could do a
yeah,
self-introduction.
I'm
for
Dr.
this.
Meenu Ramakrishnan. I'm a professor at KJ Somaya Medical College. I'm also the medical superintendent there. So actually, I do get to see a lot of issues about burnout, not amongst the ophthalmologist residents per se, but definitely amongst others. Also, when we were in our residency, we were used to seeing so many patients in a day. Like we are seeing 20, 30 admissions in a day. We are doing blood collections. We're doing all these things. But nowadays, even with a little workload, like there are 5 or 10 patients in the ward, and our students are not able to manage them single-handedly. So not as a burnout, but maybe they are not interested. Maybe they are not that concerned about the patient, or maybe they're not connected to the patient, and they feel that they can get everything done easily. So this easygoing thing, the screen that madam mentioned, Vare madam mentioned about that, the screen time that they have, and the lack of contact with people, like emotionally connected or physical contact, which they don't have. So all these things are factors which cause the burnout, or which cause them to feel maybe they are isolated, or maybe they are whatever, they're getting stuck into the work which they're not able to complete in time. So because they get stuck in a circle, they are not able to complete it. And that is why they feel the burnout. So mostly like it needs a lot of patience from our end, like we being teachers, like we need to treat them as our own children. Suppose if it was our child going through this, how would we handle it? So there is a different way of looking at things. Now, if I look at myself like 10 years back, if I had such students, maybe I also wouldn't have the patience to like to listen to them, or to like we think that, okay, we have done this, why can't you do it? So it's not like that. So the generation which has changed. So now we need to be a lot more patient with
We
our
need to stop saying in our times we used to be like this and look
yes.
how you are. We have to stop that,
Correct.
and we have to understand that times have changed,
Yes.
and we have to probably since the generation is different, we have to probably find ways
Correct.
to so that they don't feel stressed in their work and they enjoy that
Correct.
work more.
Yes, yes,
So
correct. So we give them that environment where they can grow. So we accept them. We sometimes we need to like go back. Sometimes we scold them. So that then you realize, that is not helping. So you need to change your tactics. See what works with which student. So you need to change your plan accordingly, and then work out a way which is mutually beneficial to both.
So we have planned some role plays in the coming annual conference, and in this discussion, the thought that comes to my mind is, which I'm sharing with Dr. Shweta, is there could be some role plays on how teachers and students are behaving with each other, and those could be positive role plays as to how we could make those changes so that there is a happy environment and they feel happy working and doing that work.
Yes, ma'am.
So,
That'll be really helpful.
yeah, so we'll ask you to do that role play. So,
Definitely, ma'am.
and Natasha, of course, because she has given us so many good points today.
Yeah.
So, any other panelist would like to make some comments? Dr. Rekha Khandelwal, are you there? Would you like to give your comments on this?
I
And
think,
can you introduce yourself for the benefit of everybody?
yeah, I'm Dr. Rekha Khandelwal from Nagpur. I am in this teaching for more than 33 years now and have been dealing with UGs and PGs in our college. Also, I am in charge of PG mentorship program in our institute, which started around 5 years back, where we allot mentors to all the residents in all subjects. And these are not like guides. They will not be your guide, basically. There'll be some other junior, I mean, assistant professor or something like that, not very senior people. And the student will have interactions with mentor and mentee, and that is happening for first year every 3 months. Every 3 monthly, they will interact, they will upload the data individually, the teacher as well as the student, on a platform. And what we have seen that, as Minu said, we have to be patient, we have to be positive, and we have to have self responsibility that these are our children, basically. And like our children and us, there is a gap. Like when we were children to our parents, and now we have children, there is some gap. And same gap we are observing in institutes also. And it is not a controlling time, definitely. They need more love, more care. Of course, we have to correct them like we correct our own children, and we have to be patient with them. That is, I think, more than students, teachers must have patience these days. Then only something can happen. We have to accept them. Then only we can expect something out of them. Otherwise, they have very less what you call mental toughness these days, and very often they have negative thoughts more than positive thoughts. So on simple things they would think about, should I have some pills, should I go upstairs and jump, and all those things. So constantly you have to be like, ghar mein we have a watch over our own children, whether he's sad, whether he is happy. Same way we have to practice in the institute. We have to keep looking for people who are sad or feel not doing so well. So I think it is more of mentorship which is needed these days. And rather than the back days, back years, it is more needed now because of all the distraction, all the wiring they are with their phones all the time. So that is what I strongly feel, that mentorship, and you have to be a role model yourself first, and then only they would see you, they would observe you, and they would start learning from you.
So you have to be a role model, you have to be a mentor, and you have to be like a mother.
Yes.
So from being a teacher and a student relationship, it has to become more like a mother and child relationship. And it is so nice to hear that the common thing that I hear from all the teachers is that they are coming up with, we need to change ourselves in order to adapt to them. So
Yes.
it's that's the common message that is coming from everybody. Rather than trying to change them, we need to change ourselves. So that's what the true meaning of a teacher is. The teacher is ready to adapt themselves as per the student. Any other panelist would like to give a comment before we go on to the next talk?
Yes, I'm Dr. Sai Kiranmai from Hyderabad. I work in an institute where we have just DNB students, only a few of them. So, as everybody said, I think, and the age in which they are there, also they have many distractions, due to which they face a lot of problems. Sometimes they have problems from their parents also, so parents are not allowing them to do something or something. So that time I think we have to take a role and try to make them understand in which situation. Like example, we had a girl in our hospital who wanted to leave the course because of whatever problems. Then we made her understand that even her career is important along with other things, and try to tell her how to go about the situation. So she took, and we sent her to take some treatment because she was having some depression. So we tried to make her understand, and she could follow it, and now she's again back and continuing the course. So I think we have to try to understand in what situation they are in the life, because they are in such a age, also because they have other, as everybody, they are in so many distractions at that point of time. So even I think we have to know what they are going through, even in the other outside the
Has
hospital
to
also.
again become a very personalized approach for each
Personalized. So
student.
it is not like even the
You have
outside
to
thing
give more
affect
time.
their work and their learning, because they're constantly affected because of that.
Correct. Dr. Manvi, your comments, and then Dr. Shweta, I request you to invite after that the next speaker.
Good evening, everybody, and thank you for having me here. I'm Dr. Manavi, and I head the retina services at Arvind Eye Hospital, Pondicherry. And I have been involved in training the DNB residents here as well as fellows and mentoring them. And I think I very much agree with what has been said so far, that it is an individualized approach that we need to have. And rather than thinking of the person as being a problem, we can think as to what problem are they facing, and try to get them into our confidence. And maybe, once you address whatever they have, it could sometimes be just that they might be having some personal tiffs with one of the other persons that they have to interact with on a regular basis. And you change the environment, or, put them in another group or team that they work with, that itself might help them. Or sometimes, like we are in a surgical branch, so they might be facing trouble with doing the surgeries, or and that's why their pickup is slower, and they feel then my colleague is going faster, but I'm still lagging behind. And maybe then you encourage them, or you hold their hand, take a look into what has happened with their surgical training, and add in some more extra mentorship for their surgery. So that boosts up their confidence. And the world is changing very rapidly. I think all of us can agree, when we were kids, that there were no phones in our houses and we had to go somewhere and book trunk calls. And from there, we moved to the STD booths. And then we moved to having STD phones in our house, to now we have the mobile phones, and we had computers, and now the whole world resides in this one device. So in this rapidly changing world, yes, a lot of ways and approaches of how things are seen are changing. The entire mindset towards work life balance and things that are called are changing. So we need to take that also into consideration as we devise our teaching programs and our work programs around in the world today, I think.
Thank you for all these
Thank you.
solutions. And Dr. Shweta, can we continue with the next talk and then the next round of?
Yes, thank you, Dr. Mohita. And I would just like to add one thing. But there was one student of ours who was just blank emotionally. All our faculty members used to think, why she is like this? She has no emotions, no expression on her face. And then one day she brought her father for an eye checkup, and he had Parkinson. And when we examined her, and we dilated him and made him sit outside. And when she was sitting, and she just broke down and she cried like anything. And she was also not able to control. And that was the reason why she was like this. She had so much of family problems. And that was the main reason why she was like that. And I think we need to understand our students, and then only we can improve the learning that they are getting, and that will improve their patient handling. So we actually need to be very patient and understand our students, and then only we can make good doctors out of them. So with us, we also have Dr. Subneshwari. She is also one of the pillars of WOS, and I would like to invite Dr. Subneshwari to take forward this session. Dr. Subneshwari.
Thank you, Shweta. That was really nice. And your concepts have always been very innovative and thought-provoking, I mean, how do you really reach up to this is something which we have to dig in your brain to understand, I guess. So with that, I would like to invite Dr. Kavita Arvind, who's a good friend of mine, and she happens to be the head of the department of Tirunelveli Medical College. And she's been, taking care of so many postgraduates deep south. This Tirunelveli is located in deep south of Tamil Nadu. And Dr. Kavita graduated from Institute of Ophthalmology, Regional Institute of Ophthalmology, Chennai, which is supposed to be the second eye hospital in the world. I'm sure all of you must have known, and they have celebrated the 200th year as well successfully. So now Dr. Kavita is going to be speaking on when teaching does not translate into learning, or when are we missing the link? So what are we missing? So Kavita is going to highlight the missing links So over to you, Dr. Kavita, and then after that, we will involve all the panelists and our special guests so that we can have a good discussion on the topic, which a very important topic, which Dr. Kavita is going to, bring it to over to you, Dr. Kavita.
Thank you, Shubhneshwari. Thank you for that lovely introduction. And actually, one small correction. I'm in Madurai Medical College, Madurai.
Oh,
and
sorry, yeah, Madurai
That's
Medical College, yes. You are close to the temple.
yeah. And thank you everyone for this great opportunity. I'm really overwhelmed. So let me start my screen sharing. So is my screen visible?
Yeah, Kavita, your screen is visible and you're audible also.
Okay, thank you so much. So the topic given to me today is when teaching doesn't translate into learning, where are we missing the link? So I think motivation is the engine behind meaningful education. So that is the main link that we might be missing. So who needs to be motivated? We all know that student motivation is the very important thing. They need an intrinsic motivation as well as extrinsic, like grades or recognition, coming top in the exams, all those. But as we have already discussed today, teacher motivation also is a very significant factor. How we deliver our lectures, how actively we engage our students. These are all very important things to bridge these gaps. So where does the motivation come from? Autonomy. So I think the students need autonomy in what they are being taught and how the classes are being conducted, like whether they want a seminar for this particular topic or how the assessment should be. And this class should improve their competence and they should have some relatedness. This applies also for the teachers. We should have autonomy and we should have the ability or the resource rich work environment. If we have that, the teachers also will be motivated. So before going on to what we should do in our class, I think we should know little about the learning. So this is the learning pyramid, which shows the lecture teaches the students the percentage of their retaining capacity after a lecture is only 5%. 5% of what has been taught. And by reading, they retain 10%. By any audio visual, they retain 20%, and demonstration, they retain 30% of what has been demonstrated. So these are all passive methods. So 50% is retained when there is a group discussion, and by doing, they learn 75%, and by teaching others, they retain 90% of what has been taught. So these three, the last three are active methods. So we should be doing more of active methods of education. So this is the 70-30 rule, where this suggests that the students learn better when the class comprises of 70% of active participation and 30% of teaching. Even that 30% of teaching should be just targeted instruction, moderating, and necessary feedback, how to improve. So this is where they learn better. And we should know also more about the patterns of learning of the students. So they have different learning styles. So we all know that few will be visual learners, some will be oral, that is where they remember better when they hear something. Some will be verbal, like when they write or read, they'll be learning better. Some will be kinesthetic learners. By doing, they learn. Some will be logical, like you give a sequence of events. This leads to this leads to this. So they'll be logical learners. Some will be social learners, like group discussions will help them. So we have to know the learning styles and we should engage all types of learners. Our presentation should be like to cover all types of learners to cover all the learning styles. So first and foremost thing in any case of a class should be, first you should hook the learner. How do we hook the learner? So they should not be sitting apathetically in the class. Just start by giving a anecdote or a personal life experience. So this is one thing that I did in my class. I started a TOSIS class. So I distributed a crossword puzzle to them. So here you can see in the bottom of this slide, you have clues for across and down. So we distribute this, and then I ask them to write down the fill the crossword. As the class proceeds, you will be able to get the answers and you fill that. And I definitely didn't forget to say that this will be included for their internal assessment. So this is one of the way to hook the learner there. So when you start with this one, maybe say a punchline, then they'll be interested to listen to your class. So first thing is you start with the open-ended question. Understand what they know. So we cannot go into a class with a pre-formed mind like this is a final year student, so he should be knowing this, so I'll start from this. It should not be like that. So we should try to understand their level and then start from there. So build on what they know. So if you're going to take a cataract, we cannot say that this particular batch has already attended a class or they have been in the pre-final year, they would have known what cataract is, and we should not start just with the management. So we should see what they know and build on what they know. So that is where they'll be able to follow us. So, and another thing is, so madam was saying, I think Dr. Rekha ma'am was saying that the concentration time for all the students have come down. So one of the educationalists in one of the conferences, education conference, was saying that nowadays the time limit for our attention span is like a goldfish. The human brain attention span is like a goldfish nowadays. It is 8 seconds, he said. But I don't know whether it is true or not. But they need brain breaks in the classroom. You cannot monotonously take class for 60 minutes. So they need brain breaks. What could be the brain breaks? It could be a team challenge or a MCQ. You give a case scenario and discuss case-based discussions or an active poll. So these could be the brain breaks, but be sure to keep them short. It should not disturb the class and it should not extend very long. It should be 1 or 2 minutes. So this is the comparative study I did in my ACME session. So effectiveness of case-based questions, that was a MCQ based question in the class during lecture on learners engagement, and this was the result, and the long term retention you can see here was much better when we did this. So the next is, this is another thing that you can use for brain break. So I think we have 30 seconds time. So if you can scan this and join this app, can you, all of the participants, can you please scan and join this app? Can someone respond? Is it possible to scan?
Yeah, joined.
Yeah, join. There are no active polls at the moment.
Yeah.
Okay. So now we'll go to the poll. So you'll get a word cloud. So you can just type in that. So this is your question. So what are the engaging apps so that you know for the students? Or how do you think we can engage them? So this is a word cloud and the students can type in that, so they will be actively participating. So let me see the results. So yeah, here are the results. So Kahoot is Slido app, do a joke, very good group discussion, MCQs, interactive quiz, mind mapping. I don't know what it means by Meena. Quiz, group discussion. Yes, Mentimeter. But here, Mentimeter and Kahoot, we know it is a paid app. But Slido is a free app. So even for 250 students, when you have a large group of 250 students, it is free. So this is how we engage the students. We can conduct some active poll or a word cloud like this so that there'll be interactive sessions. Thank you. Thank you for joining. And gamification. What can you do in gamification is you give points or badges or leaderboards. At the end of the leaderboard, you give small rewards to them. So, and you can give levels like that. You can set quests also in this. So this will be engaging. So these can be used for brain breaks. So at last, the most important thing is we have to summarize our class. We have to encourage friendly competition between them during the brain breaks and summarize. Give a take-home message. So that is very important. So when we give a take-home message, like in brief, we say what are the causes, what are the clinical features and the treatment options available. At least that slide, if they listen, they'll be able to reproduce in the exams. So this is for UGs. Now coming to the residents, we have actually already discussed in elaborate. As ma'am said, the belongingness and psychological safety is very important for the residents. So they come from diverse backgrounds. So they should feel that I'm safe here. The psychological safety and the feeling of inclusion should be there for the freshers who come, and then a sense of belonging, so that only when they have that psychological safety and belonging, they'll start learning. And as already discussed, so this is a very important thing when we come to the residents. So mentoring. So we are no more teachers, we are mentors. As Madam correctly pointed, we should be a mentor, role model, a parent. So we should take so many roles. So mentoring is the very important thing here. So we share our knowledge, transfer skills to them, identify specific potentials in them, and encourage them in the development of their skills, guide them, support them when they are not well, and then you coach and mentor them. So this is a very important point in case of residents. So even if we have discussions, it should be structured discussions. So these all we know. So we have give a scenario or like discussions we know how to take. I think we don't need to go into the details of this. And we should give active learning techniques. We should bridge the gap between the theory and practice in case of residents. So like doing a refraction or training them in the wet lab. So these should be the active learning techniques should be used to teach the residents. So we have to provide a professional context for them. So if you learn this, you will excel in your refraction and your patient will be happy. If you learn the skill, your patient will be happy after having a cataract surgery done by you. So this will be your goal and you will reach there. So we have to provide professional context for the residents to learn. So, and one more important thing for both residents and the undergraduate students is reflection. So this can be reflective writing can be advised, which could be a logbook maintenance or portfolio maintenance. So this helps in deeper understanding, identifying the gaps in their knowledge, consolidate the concepts, and this will help them transform a routine experience into a meaningful learning opportunity. And this will also enhance their critical thinking, promote self-awareness, and help in professional growth. So to summarize, for the undergraduates, we have to actually hook them at the start of the session itself. Start from what they know. We have to be precise. Brain breaks in between and summarize the class. For postgraduates, first we should create a very good environment, a sense of belonging there. And mentoring is a very important component here. And as Natasha ma'am said, red flags should be monitored, like repeated errors or feedbacks not translating into results or avoidance behavior. All these red flags should be monitored by the mentor. And we should use active learning techniques and structured discussions and case-based discussions. And we should make them critical thinkers. And we should also provide professional context to their learning. Now, thank you for this opportunity. Thanks again. Thank you for celebrating education with us today. Thank you so much.
Thank you so much, Dr. Kavita. Actually, what you presented was also what you taught us, because
Thank you,
there
ma'am.
were a lot of hooks there for us. We all got hooked. There were brain breaks
Thank you,
also
ma'am.
for us. And you taught us like a UG as well as a PG. So,
Thank you so much, ma'am.
actually, practically, you could depict it to us. And we may be knowing all this, but when somebody summarizes everything, in the end, you summarized also. So it comes from the back of the mind to the front, and we can actually start applying it. So I think the whole crux of the talk was that we talk so much about knowledge being there in the internet, knowledge, the screens, the students being exposed to screens, but our teaching has to be more practical and practically oriented, and that is when they will realize that this is something which they are not learning in the books, and it has to be done in such a manner that they don't get bored of it, because there are breaks, there are hooks, etc. So now, from Dr. Hema Nandini was there. I could see her. Professor Hema Nandini. Yeah, your comments, please. You are muted. Can you unmute yourself, please?
Sorry. Good evening, everyone. I thank Dr. Mohita for making me a part of this session. I am actually attached to Regional Institute of Ophthalmology, Chennai, attached to Madras Medical College. And I have about 26 years of teaching experience. And in fact, our guest lecturer, Dr. Divya is one of my UG students. And what I feel is, so far in all these years, no, you have to get close to whether to teach them, whether you make to make them learn. First thing is learning comes from comfort, and this comfort, see, they are coming from other places. So the workplace, the hostel rooms, food, language barriers, so many things are there in their mind, and all these should be sorted out. Then only they can involve themselves totally in learning. So for this, what we should do as mentors is you get close to them. In fact, in our RIO, we have around 30 postgraduates, and each postgraduate has a mentor, either a senior assistant professor or a professor. So you just got earn the trust. You go, we become close to them, connect to them, know all about their health issues, family problems, so many things. If you earn the trust, automatically they start listening to you. That's my experience I have seen in all these years. And once you make them stay comfortable, then they start learning, they start listening to you also. And most often, some of the students from other states, language barrier is the biggest problem. And even though they are brilliant, initially it will happen that they stumble a lot, and they find it difficult to manage. So this has to be taken into consideration, because so many of our students, they learned Tamil only after coming to Chennai, and initially they had a lot of problems. And coming to teaching learning methods, Dr. Kavita has beautifully spoken about this. And any class should start like you break the ice, talk to them. You can even make some non-academic methods of involving them, so that instead of starting the class in the beginning, you can just break the ice. And what pattern we follow is we have different teaching learning methods. One day we have clinical discussion, one day we have journal club, CME, guest lecture, like that. So it keeps changing and it kindles a sort of interest in the patients. And another thing is we always give them a free hand and allow them to do anything or perform under supervision. They are even, you can tell them they are allowed to do mistakes under our supervision so that we can always take over. And supervised performance is always better for the students. They get confident after some time. So what we see is when the student joins in the first year, they get molded beautifully, and the final year we can totally trust them. This is what we are experiencing in our RI. So basically, this all starts from the trust with the teacher, and that we have to establish when they come in the first year. Thank you.
Thank you. So going back to your student and our special guest, Dr. Divya Manohar again. So I also wanted to your comments. Plus, do you feel that there is a difference in the behavior of the girls and the boys as far as all this topic is concerned, and a different way in which you have to deal the two genders as students?
Yeah. So one thing that I wanted to say is we see a lot of women in ophthalmology these days. So even as residents at Arvind, almost about maybe 70-80% of the students we get are women. And what we should understand is there is this societal pressure. The women is empowered, but the society is still not empowered to accept these women. So they have the burden of running the family, taking care of their in-laws, taking care of the child, and apart from that, apart from their education. So I think that is something that we have to understand as women ourselves, support them as, like, all the other speakers have told us. And somewhere I see that men are practically, they're able to pick up much more earlier than the women. I think it's more about the skills. Men are good at it in general, but women are also equally good with a little more training. When they get a little more training, I think they're able to perform equally well. So I think that is our observation. And the other one more method that I follow while teaching students is, most of the times it's like we teach and they learn. So when we give them a topic and ask them to prepare and teach, I think then there is more investment from their side. So, as long as, there is, the learner is not invested, then the learning will always remain very superficial. So I think it is good for them to be involved, ask them to take classes so they read about it more. There is no, there's no dearth for material. Everywhere you find materials, like what the previous speakers have spoken. You have the internet. A lot of these students have this attitude that they can learn surgeries by just watching videos. They don't understand that watching is different and performing is different. So I think we have to get those ideas clear in their mind, that watching and performing is different. So involving them, and I think gives us an edge.
Correct. So, Dr. Shweta, you don't have a rapporteur today like you have in all the webinars, because such
Yes.
important points are being discussed. I thought it would have been a good idea to get them compiled and be shared with everybody else, so that all these ideas go to all the teachers across the country.
So we'll compile them and share in the teachers group also.
It is
And
being recorded also. The meeting is being, so one, you could appoint one rapporteur. That somebody could volunteer from here.
so I think many are there who would like to volunteer for being the rapporteur, or we announce it. Dr. Sneha, Dr. Meena, anyone? Dr. Priyanka has already done, so I'm not asking her to do it. So we'll get it done. And in the next,
You can find whoever is this thing, and then you could actually get these points compiled. And
Yes.
Any other comments from any of the Dr. Natasha? Would you like to say anything on the last talk and that topic? Right.
Yeah, just a simple thing that I follow during lecture classes, especially for the UGs, is to walk in the class, which I find very little teachers do that. So, because you have a huge class of 200 students, if you just stand in front and keep on lecturing, how much ever interactive you make it, it will not shift their attention. But if you are walking up and down, one, you can catch all the people who are, watching their phones or looking at something else at that time, but it also keeps them engaged because they are also engaged in watching you. So at least little bit they are more
Is there
active
more
in their
connected? Yeah.
attention. So that is something I always ask for a cordless mic, and I always walk around in the lecture class. All the other points that ma'am said are very, very relevant to give a little bit of attention break in between. Even talking about something that is unrelated to the class is important after about 20-25 minutes. It's good to take a 5-minute break and do something else. So I make it a point during a 1 hour lecture to definitely do that. Yeah, this mentor-mentee concept is also, it's been there for like, I think when I was in Trivandrum Medical College in way back in 1990, we had mentors. Like first year physiology ma'am, one of the ma'ams was my mentor. So that has been there always. So it's something that has been always, especially in the first year, residency and MBBS first year, to have that one person whom you can go and tell all your difficulties to, who will give a listening ear. I think that's very, very important.
I have
Yeah,
I have
Yeah.
to add something. It
Yes.
was a wonderful talk, Kavita, and whatever you said is really, you have covered everything. Certain two things I want to add, which I use in my PG program. One is after clinic discussion. So when a resident is with me in the clinic, after the clinics are over, just we pick up 2, 3 important cases and we just give them simple bite-sized information. What was that case? What did you learn? And I feel we should teach them how to ask questions, because that is very, very important, that they should be promoted to ask questions and not fear uh, that asking this question might have a negative impact on us. Similarly, while doing surgeries, when I finish a case, I usually ask two questions: what went right, what went wrong, what could have we could have done where. So just to, so that they are with me in the clinic, they are with me in during the surgery also, and we also understand what they are learning basically with us. So these are simple 2 minutes talks which are very, very important to connect with your resident. That is what I feel.
Definitely, ma'am. And Dr.
in modern
Signeshwari, anything
teaching,
from you?
in modern teaching technique, your technique has a name, ma'am, 1 minute preceptor.
Yes,
Yeah.
I am MET actually chairman in my college. So,
Yeah, Dr. Signeshwari.
Yeah. So actually, it is a wonderful point which was getting highlighted, the concept of small group discussion. Rather than having a huge class of 100, 150 people, for 100, 150 and all, it's going to be a didactic lecture. But if you have to drive in certain points, then it should be a smaller classroom, because only then your group discussions will materialize. And at that smaller classrooms, when you are conducting, it's like a table discussion which we do, like coffee and discuss. So at those points, it should not be, they should never use a PowerPoint presentation. That has to be only a pen and a paper, and then you sit in a group and have an informal chat. That is when more points start overflowing. So, and you could keep it anytime on a Sunday morning or something like that, whenever you feel comfortable with your fellows to do it, or on an evening day, something like that, Saturday evening. But we tend to kind of do that, and we find that most of the fellows, they come out with their problems in terms of where they are not able to manage kind of doing a retinal surgery, where are there troublesome difficult points. So you see that when they are in a smaller group, they open out better, and they're able to express themselves, rather than being caught in an entire class when they're not able to gel around. And we also kind of identify people who are like-minded, so that that gang should have only friends among themselves. It should not be people who don't get along well. So you don't put the people who don't get along, team A and team B, mixed together, and then you conduct, and that will not be helpful. So you must tell them that you build your own teams, divide among yourself, and then that group will have focused small based discussion, which is like really meaning, and we tend to see it is producing useful results as well.
Correct. So I think that was a very useful discussion. So Dr. Shweta has promised to get it all compiled, and we will continue more of these discussions during the annual conference. And as we discussed today, we would have some role plays also, and we'll encourage some of you to come up with those role plays, so that those role plays will have more of an impact on the audience also, and better understanding, as we have gathered from all the discussions today. And here I also want to announce that 15th to 17th October is the annual conference of WOS. And this is in New Delhi, and we've already announced the conference after a lot of going here and there for the dates, because every weekend is full of conferences. But yes, WOS is a totally different experience, and we encourage a lot of teachers and want a lot of teachers to come, because we have a separate Teachers Connect program for them there also. In fact, that is where it started. And WOS always promises complimentary accommodation to the teachers as well as to their students. The reason is only we want to encourage you to come with your students, because that is again one way of bonding with them when you travel with your students. And you, or even if you don't travel, you may come on different timings, but you are there for your students like a mentor during the conference, because we feel during the conference students many times become lost when they go to other conferences. But if they have their teacher or a mentor with them, they always feel better. So with this, last comments from Dr. Shweta Walia, or if anybody wants to speak anything, then you are most welcome. Dr. Shweta, if you could close the session, your last comments.
Okay. So with this, we come to the end of this lovely session, and I think everyone had a good learning. And one thing is clear, that teaching is not one size that fits all processes, and it requires a continuous reflection, adaptability, and empathy. And it is basically we need to connect with our residents, and then only teaching will be complete and learning will happen. And I would like to thank our special guest, Dr. Divya Manohar, and the speakers, Dr. Natasha and Dr. Kavita, and our panelists, Dr. Rekha Khandelwal, Dr. Sai, Dr. Hema Nandini, Dr. Manvi Sindal, and Dr. Meenu Krishnan, and everyone over present over here. And we had a lovely discussion. And let's continue to evolve, not just as clinicians, but as educators. And thank you, everyone, and have a wonderful evening. Thank you, everyone, for joining. And
thank you.
Thank you.
Can we have your cameras on, and we can have one group photograph, so that keep it as a
Tarikji, are you
memory?
there?
Yes, ma'am.
Tarikji?
Yes, ma'am.
Okay. So cameras on, Natasha,
Yeah.
Dr. Sai. And
Done, ma'am.
no,
Thank-
Abhi, Dr. Meenu has just joined. One more.
Okay, ma'am.
And with Dr. Shweta's photograph as pinned. Okay. Okay.
So hope
Good
to
night,
see
everybody.
Good night.
night.
Thank
you
you.
all
Good
soon.
night.
Thank you,
Good
ma'am.
night. Thank you. Thank you.
you.
Bye.
See you all. Thank you.
Thank you, ma'am. Good night,
Thank
everyone.
you.
Night.
Thank you very much. It was a nice learning.